Hello, everybody. Welcome to the Douglas Laboratories Educational Webinar Series. Today's topic is men's hormone health, hypogonadism, and endocrine comorbidities. My name is Christy Belolovic, and I'll be your moderator today for Douglas Laboratories webinar. And today's presenter is Dr. Joseph J. Collins. Dr. Collins is an internationally recognized leader in the field of functional endocrinology. He is an experienced medical educator and presents many lectures to physicians, pharmacists, nurse practitioners, and other healthcare professionals on diagnostic and therapeutic applications within the integrative functional medicine model. Dr. Joseph Collins is licensed by the state of Washington as a primary healthcare naturopathic physician. He is a graduate of the Natural College of Naturopathic Medicine in Portland, Oregon. He is the co-founder of YourHormones.com. With attention to highly individualized care, Dr. Collins' protocols are available on his website, YourHormones.com, for healthcare professionals who use natural and integrative therapies. His customized therapies include a focus on functional medicine as a primary approach to menopause, andropause, adrenal fatigue, thyroid dysfunction, insulin resistance, and fatigue disorders. Dr. Collins is a clinical advisor, researcher, and developer of 6 hormone-specific formulas available through Douglas Labs. So just a reminder to everybody that you will be muted during the presentation. So we will take questions at the end of the presentation, and you can submit those questions in your toolbar on the screen. So without further ado, let's get started. I'd like to turn it over to Dr. Collins.
Thank you, Chris. It's an honor to be able to present this information to a wide audience today. Today, as you mentioned, we're going to be focused on men's hormone health with an emphasis on the hypogonadism and the endocrine comorbidities. We'll, of course, be talking about decreased testosterone function and some of those problems that occur with both aged men and men with diseases and different disorders. And then we'll also talk about some of the endocrine dysfunctions that are closely associated with that. And of course, we'll spend the last minute or two talking about prostate health, because that's an integral part of men's hormone health as well. I think you've seen this is the classic copyright information here, and you can read this on the webinar. This will be posted on both Douglas's websites, a video, and on YourHormones.com's, Your Hormones Incorporated YouTube as well. So you'll be able to see all of these on video for review. She presented you my bio already, so you understand my background, and that can be reviewed in the future as well. Here's the webinar objectives. Our objectives are that upon completion, you'll become very familiar with the broad scope of testosterone properties, not just the one or two that come to people's mind in the beginning, and the physiological effects on men's health, as well as its effect on primary and secondary male characteristics. We're going to review those. Many of you know those. We're going to review them. We're going to understand primary and secondary hypogonadism. What's the difference between primary and secondary, as well as the varying symptoms of low testosterone function. We're going to review the best diagnostic test to assess and monitor male hypogonadism, which involves a little bit more than just measuring testosterone. And because we'll look at some of the other endocrine comorbidities that can affect it. We're going to become very familiar with the phytotherapeutics for low testosterone and the specific actions of each agent, what the peer-reviewed literature says on each of the individual constituents, and I'll show you how you can access the scientific references on these. At the end of this webinar, you'll understand the effect of endocrine comorbidities such as adrenal dysfunction, thyroid dysfunction, the effect of insulin resistance, and the correlation assessment of these comorbidities. Are they correlated with the condition, or are they independent, and the different therapeutic interventions. When you look at testosterone, we first of all want to understand its properties. What is testosterone? What does it do? Primarily, it's a steroid hormone. It's made in the steroidogenic pathway we'll review in a second, which primarily comes from cholesterol. So the first question that raises up is, what's the consequence of using cholesterol-inhibiting drugs? And the consequence is, yes, they can lower testosterone. It's well documented in the literature. We know that they can inhibit the steroidogenic pathway. When you lower cholesterol, and specifically, it's the LDL. We call that the bad cholesterol, but LDL cholesterol is the pool of cholesterol that's used to make steroid hormones. So you can imagine you do not want testosterone levels to be so low. It raises questions as to maybe that's why people that have their LDL lowered so low have a high incidence of suicide, knowing that low testosterone is associated with severe depression in both genders. So number one is you don't want your LDL bottomed out, and recognize that bad cholesterol isn't all that bad after all. Its properties are androgenic. Androgenic specifically means what we can call masculinizing features, and we'll be discussing some of those when we talk about male sexual characteristics. Anabolic means tissue growth or nitrogen growth or protein deposition, and that can include not just the anabolic muscle that we look at, the muscle-bound weightlifters, but we can also recognize that anabolic has to do with skin collagen, bone collagen. So, you know, the aortic tissue, all the connective tissue in the body requires good anabolic function. So we do need anabolic tissues. Hematopoiesis, the creation of red blood cells, is dependent upon anabolic activity. So anabolic is much more than muscle-bound picture that comes to people's mind, first of all. Testosterone in and of itself increases nitric oxide expression in the tissues, and that's one reason that's involved in both blood pressure stability and, of course, in sexual function. Another attribute of testosterone is it increases dopamine. Now, we understand dopamine is a neurotransmitter that has to do with drive, not just sex drive, but other drives as well, and mood, motivation, drive. So it's very important in that. Quick side note, just as testosterone can be associated with dopamine, we can remember that progesterone is associated with GABA, and estradiol is associated with serotonin. So you see that the primary steroid hormones have very close relationships with the three primary neurotransmitters in the body. This is the steroidogenic pathway. I think we've all seen this countless times over the years. So don't belabor it, except to remind us all that, you know, cholesterol isn't as bad as we think it is. We do need enough cholesterol to become the pregnanes, the pregnenolone, progesterone, and the 7-hydroxy metabolites of those. And then it can go over to become the glucocorticoids, including, of course, cortisol, the strongest of all the glucocorticoids. The androgens come off of the pregnanes, and DHEA is primary adrenal, as is androstenedione and estradiol. And, of course, testosterone is produced primarily in the testes, which can be supercharged by 5-alpha reductase into dihydrotestosterone, which is more androgenic than testosterone is. And then, of course, if they get aromatized, they become estrogens. One of the things I know in this version of the steroidogenic pathway is we need to keep in mind that even though estradiol can become estriol, which the real name for that is 16-alpha hydroxyestradiol. Estrone is 16-alpha hydroxyestrone. Remember, we call that the bad estrogen. Estriol we think is good, but it's not that far away from being that. So if this level gets too high, and as you understand, this enzyme right here, 17-beta hydroxysteroid, can actually go back and forth. I need to edit that again. Can actually go back and forth between estrol and estradiol. So, in fact, estradiol gets oxidized backwards into estrone if we're not too careful. And keep that in mind. You don't want estriol too high, especially. That's why I don't like to give it orally. Just a side note, women's health. And that's also why we look at 16-alpha hydroxyestrone in men, because it can be carcinogenic in the prostate tissue. The actions of testosterone in men, primarily we look at development and maintenance of male characteristics. What we call the primary male sex characteristics, structurally, of course, is growth and enlargement of the penis, growth and enlargement of testes, growth and enlargement of prostate, behaviorally sexual desire, behavior and function, and reproduction and fertility. These are well-known properties of testosterone, the characteristics of them. The secondary characteristics are involving increased muscle mass and strength. This is why men have larger muscle mass than women. Lower body fat percentage, if we're lucky. Typically, when men have higher testosterone levels, then they have increased body mass, lower fat mass. Unfortunately, as men's testosterone drops and estradiol levels come up, then men start to develop different body fat distribution, and they lose that androgenic picture and start to develop body fat even in pictures where they're not areas that were primarily considered female body fat, such as the breast and hip, stuff like that. So when you see gynecomastia and hip development in men, it means that their testosterone is dropping and their estrogen is rising. Growth of facial hair and body hair in men is due to testosterone. Enlargement of the larynx, Adam's apple. There's a greater mass of anterior thigh muscles. So when we talk about increased muscle, interestingly, the papers have shown that specifically you'll see the extremely large muscles like the anterior thighs are proportionally much larger because of testosterone. As a general rule, the bodies are larger in men that have higher testosterone levels. And of course that has to do because anabolic is involved with the growth of all tissue. There's also large internal organs, the heart, the liver, the kidneys. All these organs are proportionally larger because of the influence of testosterone. Again, the anabolic effect is much more than skeletal muscle. Men have coarser, more rigid skin with more oil due to the effect of testosterone. Again, part of that's the anabolic and collagen deposition, and also because of the increased sebum production. And the waist-to-hip ratio is usually smaller in men that are healthier. Because they have smaller hips because of what testosterone does to body height as well. So these are some of the functions of testosterone as far as primary and secondary male characteristics. To look at gonadal function and how the body makes testosterone, a review of the hypothalamic pituitary gonadal axis is of course in order. The hypothalamic pituitary gland instructs the testes to make testosterone. Is called the HPG in short, hypothalamic pituitary gonadal axis. Hypothalamus secretes gonadotrophic releasing hormone, which then goes down to the anterior pituitary gland to release FSH and LH. These collectively are called gonadotrophic hormones. These gonadotrophic hormones have different effect on different cells within the testes. LH stimulates the Leydig cells in the testes to produce testosterone. And FSH stimulates Sertoli cells in the testes for production of sperm. So gonadotropic hormones may be lower in men with chronic illnesses, as an undesirable effect of aging, in men with hyperprolactinemia, and other hypothalamic pituitary disorders, including a number of genetic ones. Low levels have also been observed in obesity and starvation. So a number of things can cause hypogonadism in men, and keep in mind that chronic illness is one of those that we're really starting to understand the consequences. Men with diabetes, men with chronic cardiovascular disease, and of course men with any autoimmune disease, even men with diseases that we think like asthma and stuff like that. We're seeing that chronic illnesses are associated with men losing this testosterone at a younger age. And of course, men that have been struggling with chronic diseases since their adolescence, they may wind up showing biochemical signs of andropause in their 30s, and even late 20s because of the effect of chronic illness on gonadal function. So when we talk about hypogonadism, which is a term of what is low testosterone levels, is referred to hypogonadism in men. There are two major classifications of hypogonadism, and understanding the difference between the two can be helpful in determining treatment options. Primary hypogonadism is when the gonads themselves are the cause of the problem. This is because of something genetic such as Klinefelter syndrome, undescended testicles in males, infection, injury. Many cancer therapies will knock out testosterone, will destroy the testes, chemotherapies. Hemochromatosis, excess iron in body tissues. That's why it's very important when we see men with a myriad of, they have the hyperpigmentation. That's very classic of hemochromatosis, especially in lower extremities. Part of the aging process can be because of primary hypogonadism, where the testes is deteriorating function. Oxidative stress plays a role on deterioration of testicular function. Another reason to take our antioxidants, and of course excess stress and the effect of hormones that the body makes because of high stress can directly affect the testes to decrease testosterone function. Specifically, as we know, cortisol can cause male hypogonadism by directly affecting the testes, as well as causing some secondary problems as well. So that should be in both areas. which it is, as you'll see. Secondary hypogonadism is due to problem with the pituitary hypothalamus. So if you look at primary hypogonadism, the testes of the primary gland we'll talk about, so that's where the problem lies, in the primary tissue. Secondary is we're blaming, or we're recognizing the cause actually, is because of other tissue. So testicular function is secondary to hypothalamic pituitary axis dysfunction. That can include other genetic problems such as Kalman syndrome, pituitary disorders, medications. A lot of medications actually can affect the hypothalamic pituitary function, will affect ultimately the gonads by secondary hypogonadism. People on chronic opiates, that can suppress HP function, which then in turn can cause the secondary hypogonadism. Some prescription hormones that can do that, of course, prednisone. Endogenous hormones such as too much estrogen can cause secondary hypogonadism, again because they're shutting down the HP axis. Hyperprolactinemia can shut down the HP axis. And actually, I was reading a paper just today that it may actually have an effect directly on testicular function. So we may have to, as of a couple hours ago, we may have to look at the fact that hyperprolactinemia can cause both primary and secondary hypogonadism. Obesity can affect the HP axis, inflammatory diseases, the aging process, excess stress. Anything that can affect the HP axis can cause secondary hypogonadism. So one of the questions that you think about now is, well, does that mean everyone with adrenal fatigue is at higher risk for hypogonadism? How about men and women? Are they both? The answer is yes and yes. Increased adrenal stress, it's affecting the hypothalamic pituitary axis, will affect testicular function, and of course in women will affect ovarian function. So HPA dysregulation can often contribute to hypogonadism, and we will be discussing that as we go through the different endocrine comorbidities. Diagnostic tests. The first thing we think of is let's measure testosterone, and of course that is correct. We want to measure testosterone, but testosterone alone is not only incomplete, it actually gives us inaccurate information. It's actually almost dangerous to just measure testosterone because it gives clinicians and patients false beliefs about the health of their testosterone function. And one of the best examples I can say right now, as I'll show in a few minutes, is the testosterone to estradiol ratio. I've had a number of men come to me that were on testosterone replacement therapy, and the testosterone was very healthy and robust, and they were doing very poorly, and they were not being followed properly, in my opinion. And we measured the estradiol and the estrone; they were through the roof. So these men were converting the estradiol and estrone into we're making estradiol and estrone from the high testosterone, and we had to remediate that before they felt better. So so obviously, as well as look at testosterone, you look at peripheral conversion, measure estradiol and estrone as a minimum. Estrone is important. We used to just measure estradiol in men a number of years ago. Then we realized that some men, they aromatize into estradiol, then they oxidize into estrone. So you need to measure both of those to get the good testosterone estradiol relationship there. DHT can also be important to measure because how much of the testosterone is being converted to 5-alpha reductase, which is, as we understand, supercharged testosterone, which can be beneficial, but too much of it can have a negative effect on prostate function because of eventually the prostate becomes hypersensitive to these high androgen levels, as we can see. Adrenal function is important because testosterone as an androgen anabolic works best when you also have adequate DHA levels. So again, people that have plenty of testosterone and still feel signs of low testosterone hypogonadism, we get the DHA levels coming back up and they feel great. And the testosterone stays the same. So DHA is a synergist to testosterone. The cells respond to DHA independent of it becoming testosterone. We used to call DHA a precursor, a wannabe hormone. It can't wait till it grows up to become testosterone. But in reality, DHA is a hormone in and of itself. Again, without enough DHA, testosterone will not be as effective in the human body. Cortisol, because of adrenal stress, if it gets too high, has anti-androgen properties. Progesterone has anti-androgen properties. So both of those should be considered important to measure as well. And just as the body under stress can create more cortisol, there can be a phase in the stress cycle when it can actually make excessive progesterone, and the progesterone has, as I said, as an anti-androgen, can have properties that we don't want. And obviously, if people self-medicate with progesterone, that can have consequences. I remember in the 90s when there was a progesterone fad, they even got men to start using it, and men were putting progesterone on them, you know, for I don't know why, to be quite honest. But scientifically, there's no real validation for the massive doses they would give themselves. And of course, they wound up with hypogonadism and stuff like that. So, yes, progesterone is beneficial for men's health because it's an adrenal hormone. You don't want too low, but there's no scientific evidence that massive doses are going to make you better, and men are going to always cause problems. Keep it within the normal physiological range. Pituitary function is important. We just talked about the gonadotropic hormones, FSH and LH. Those are important to monitor so that you can right away say, okay, your hypogonadism, your low testosterone, is it primary or secondary? Well, at the same time I get your lab test back, they show me your testosterone, your estrogen, your DHT, your DHA, cortisol, progesterone. I want to look at FSH and LH, because if they come back weird, the next question is, now let's send you back to the lab to measure FSH and LH. So it's very beneficial to measure those two as well. And for the same reason, we look at prolactin, because if there's something going on here, you want to know if it's prolactin. Now, you can do these in series. You can do, you know, a couple of them first, but you're not going to have the full answer until you get FSH, LH, and prolactin, so you can rule out if it's primary or secondary based upon those two we discussed. And another thing that's interesting as well is SHBG. As you understand, the liver makes SHBG. It's a protein, sex hormone binding globulin. But what's interesting about SHBG is another name for it is TEBG, small t, small e, capital BG, testosterone estrogen binding globulin. It has a high affinity for binding testosterone, even though it's induced by estrogen. And if that gets too high, you can see the problem. We're binding up the testosterone, and there'll be a feeling of low testosterone, even though the, quote, total testosterone levels are adequate. That's the reason why we want to measure free testosterone as well if we can. Or you can calculate free testosterone by looking at testosterone total and using formulas to calculate that with SHBG and albumin to calculate the free testosterone. The reason we want to know SHBG, because it is high, most of the time it's due to estrogens, and it may encourage us to use estrogen detoxification formulations to help the body lower estrogens that can cause a drop in SHBG levels. Other diagnostic tests to consider is thyroid profile. I mean, one of the reasons of hypogonadism can be thyroid disease. And the thyroid disease, we're going to talk when we talk about comorbidities, can be quite, people with hypothyroidism have a high incidence of male hypogonadism, men do, of course. So that should be tested as well. So if you have a gentleman that's showing low testosterone symptomatology and signs and symptoms, and then he also has a picture that, God, I can't tell if it's thyroid or testosterone, then thyroid would be very appropriate to work up. In fact, papers go back and forth in debates. There was a couple of papers that said every male with hypogonadism should be worked up for thyroid, and then one paper says, well, we don't really need to do that. There's not enough evidence to say that. So you as a clinician, the patient, if some of the symptoms filtering through suggest it could be a possibility of low thyroid function, then it behooves us to test that, because if it is hypothyroidism, just fixing hypothyroidism does return testicular function based upon both published literature and some of my personal experience working with patients that have had hypothyroidism. You know, of interest, I was mentioning, talking about thyroid function to another clinician the other day, and with a male patient, and they said, well, isn't it rare for men to get hypothyroidism? And yes, men statistically get less hypothyroidism than women do, but there are quite a few men that do wind up with hypothyroidism. When you see families that, you know, all the women have hypothyroidism because of Hashimoto's, then we're starting to see the entire family, men are being affected as well. So don't rule out hypothyroidism as a cause of hypogonadism in males. One of the most important things when we look at lab tests is to look at them with more precision. My background, for those of you who don't know, is I spent a couple of decades working in about 5 different diagnostic laboratories. I was kind of like a turnaround guy and helped bring new tests on board, and mostly clinical applications and interpretation, etc. And one of the things that we've seen in both specialty labs and in mainstream medicine, if you look at the PubMed and the literature on diagnostic testing, is there's more and more attention being given not just to is it high or low, but where is it within the normal reference range. A couple of decades ago, going back to research, there was very few papers compared to this these last few years talking about quintiles and quartile analysis. Now, quartile is you break the reference range into 4 pieces, and of course, quintile is 5. And the diagnostic lab test literature is now saying that certain tests is saying, well, people in the first are better or worse than people in the third or fourth, and there's actually a recent paper talking about people in the third quintile and the real tightly close to the 50th percentile are better. And we're going, well, yeah, that makes sense. We'd expect that. Like if I say to you testosterone's right here, would you be happier if it was here at the very low end in the first quartile or it's over here in the fourth quartile? Obviously, as a male, you'd want it, over here somewhere, third and fourth quartile, depending upon your prostate cancer history and your family. But the thing is, like for instance, we took saliva testosterone, and the normal range is 31 to 192. The patient is 65. And the first impression is, wow, that's pretty good. You have normal testosterone levels. Well, what you do is you can figure out the percentile analysis by the patient value minus the low reference range, divided by the high reference range minus low reference range, times 100. And that's what we did down here with the math, 65 minus 31 divided by 192 minus 31 times 100. We get 21. So the patient's in the 21st percentile. So these patients, I say, well, your testosterone's within normal range, but 80% of healthy males have better testosterone than you. And furthermore, if you look at the, I put low in parenthesis and high in parenthesis, 2.5% of the male population, they're okay with the low percent of testosterone, that first little part of the Gaussian curve, and 2.5% of men actually have higher testosterone is healthy for them. So remember how we arrived at these reference ranges and interpret them accordingly. I've said this a number of times, but many times when I was teaching other clinicians about how I look at lab tests, I would say, every once in a while, look up from the report and see how the patient's doing. I read lab tests through the eye of the patient, and if a patient is even in the 40th percentile and they feel miserable, they may have spent their whole life in the 60th or 70th or 80th percentile. And so they've dropped from the 80th percentile down to the 40th. They feel miserable. We're telling them it's wrong. So keep that in mind about the patient's history, how they feel now compared to how they did then, and what we suspect could have happened. And is it normal or is it ideal for them? Ideal levels, the ideal level for each patient is based upon your clinical skills to say, hey, you'll be okay at 21%, or no, we need to get you back up to 60%. Another important way of assessing lab tests is ratio analysis. I think some of you know, if you read my book and are familiar with what I've been doing since the 90s, is that the PD ratio that became very popular in assessment of menopause is something that I introduced to the industry back in the early 90s when I was working in a laboratory in Seattle that then became a laboratory in North Carolina. And ratio analysis is very important because people wonder, well, is there enough? Back then it was progesterone to estradiol, but now we're looking at testosterone to estradiol. Testosterone's, quote, in the normal range, but is it really healthy compared to estradiol levels? And the testosterone to estradiol is the most researched ratio analysis now. There's been quite a few papers that have come out since those years. The proper way to do it, though, is looking at it in molar ratios. One of the mistakes we saw with PD ratio analysis, and we're starting to see a couple times now with TD ratio analysis, is you do not compare picogram to picogram. Those are called gravimetric units, because on the same weight of testosterone and the same weight of estradiol, you're going to have different molecules of testosterone, different molecules of estradiol. So even though I'm going to belabor this point, molar ratios should be done on molar units, not gravimetric units. Because if we were to compare picograms to picograms, there's going to be a 16% error, as if you compared it, picomoles to picomoles. And so the normal estradiol range is going to be 4.1 to 181.3. And this is something that you can do quite easy. If you look at the molecular weight, divide by 1, multiply by 1,000, you get the conversion factor. And that conversion factor can convert picograms to picomoles. Here's a reference down here. The AMA Manual of Style.com has a conversion table that you can use to go online and get these conversion factors. And you can do these for any hormone, a lot of different agents. Ratio is very important. We never look at a hormone independently. We look at how it is in relation to other hormones. And TD ratio analysis uses this methodology, and it's very, very valuable because many men with normal testosterone and the estradiol, is, it's quote in normal range. Well, yeah, the testosterone is the 20th percentile, the estradiol is in the 60th percentile. So guess what? Your TD ratio is off, and that's what we're seeing some of these problems that were missed for years. Again, low normal testosterone and quote high normal estradiol could be hypogonadism relative to TD ratio analysis. Very important. The general symptoms of hypogonadism, wait a second to get it right, okay. One more time here. Okay, the general symptoms of hypogonadism, as we understand them, they can be general physical symptoms, including decreased lean tissue mass, decreased muscle mass, and increased body fat, the opposite of what you'd have if you had good testosterone. Weight gain, we've all heard the old saying, fat burns less calories than muscle, and that's true. As the body increases fat storage, it is less calorimetric than muscle is. So muscle burns more calories than fat, so we have weight gain as we're losing lean muscle and gaining fat muscle. We wind up with joint and back pain more often. A lot of the patients that have joint muscle tendon ligament pain, it's because they're in a hypoanabolic state, and loose ligaments and tendons and poor muscle control of joint stability can be a significant problem. I mean, one of the therapies is to strengthen the joint, with exercises. Well, how you really make sure that they come back is your testosterone adequate? So people, when you see patients that wind up not holding on to chiropractic treatment and the muscles and ligaments are too weak and flaccid and their joints are unstable, ask yourself, is there enough testosterone? Skin in males as we age becomes decreased in firmness and fullness. Obviously, we'd expect that with low testosterone. Headaches is interesting. I'm interested. I've seen this in the literature quite a few times in patients. To be quite honest, I don't understand the full mechanisms, except it may be because we understand that testosterone has an effect on vascular function. But there's a high incidence of headaches in actually both men and women when testosterone levels get low. And anemia, of course, testosterone is hematopoietic. And yes, men become anemic too. I was shocked how many anemic men I've seen out there. So look at that as well. Little side note, it's very important that when men come to us with fatigue, we do a CBC on them. Some of those old boring tests can open up a wealth of information. I've seen a number of patients that they can be fatigue disorders and they were actually anemic. So test that first. It's embarrassing to find it after the fact. Energy and strength symptoms are affected by hypogonadism. Men who complain of feeling tired and fatigue, they feel weak or decreased endurance. All these are associated with low testosterone, of course. Now, yes, there are other causes as well. We need to make sure that we're not dealing with men that have the progression of cardiovascular diseases or pulmonary diseases or sleep disorders, etc. Which brings up a point. Sleep symptoms. Men are more likely to, as we age, become sleep apneic. And that sleep apnea can also be one of the causes of hypogonadism by affecting HPA and testicular function. So look at proper sleep functions. Independent of sleep apnea, low testosterone will cause increased incidence of insomnia, difficulty falling to sleep, and difficulty staying to sleep. Very similar to what women experience with low estradiol. So in both genders, our primary sex hormone is important for sleep function. And, of course, night sweats. And yes, in both men and women. We know that women have night sweats with low estradiol, but women also have with low testosterone. Men, if our testosterone levels get low, we can start to have night sweats. This is real evident in men that have chronic illnesses and the testosterone drops pretty quickly, faster than it should. And also men that, of course, had testosterone ablation therapy because of Lupron or because of testicular removal because of prostate cancer. One of the common symptoms is night sweats. So this can happen to a lesser degree in men going through andropause a little too fast. Neurocognitive symptoms are pretty severe when testosterone is low. There are decreased mental skills and decreased memory function. Men can't solve problems as well, and they have trouble focusing their attention. If you look at testosterone's neurocognitive action, the best way to describe it is testosterone has a lot to do with motivation and drive and attention. So when testosterone levels get low, I've seen these men that go, I think I have attention deficit disorder, or ADHD, as an adult. I said, well, when did this start? You know, he's in his 50s or 60s, and all of a sudden he has adult onset ADHD. It's testosterone. When testosterone gets low, all of a sudden you can't focus on a task, you can't solve basic mathematical problems, and etc. Testosterone helps us with linear thought processes, get from task A all the way through task Z. So that's linear cognitive processes, whereas estradiol is more lateral processes, whereas the woman she has better peripheral vision, she's better associating different objects with other things. That's estradiol. But testosterone is linear progression, linear thought processes, problem solving, focus and attention. When those drop in either gender, look at testosterone. Events instead of names, because events are linear in the fact that they happen in a sequence of time. Men and women lose the ability to remember events. Like many times the wife will say, because the wife has such good associative memory, she can remember events, which is interesting. Men can't, she goes, don't you remember this? And he goes, I can't remember that, because of low testosterone. And they're easily confused because they lose some of these linear time events. That's low testosterone. It can appear like a dementia, but it's actually low testosterone. Mood and behavioral symptoms, high incidence of depression in both genders. Social isolation, I used to say, that's because they're afraid of going outside. Agoraphobia, agoraphobia, yeah. Agoraphobia is fear of bunny rabbits with long hair. Agoraphobia is social isolation. And so we see agoraphobic behavior in both genders when testosterone levels get low. They pull away from family and friends and social interactions. They're less motivated, irritable, mood changes. It's interesting, the irritability and the agitation we see in men as they age is because of low testosterone. Healthy testosterone levels, many easier to get along with compared to when they get low and they get more irritable and less motivated, and then they don't want to do anything anymore, and their wife's always having to remind them to do the basic tasks. A lot of that has to do with low testosterone, which gives a point to comment on the fact that when a woman goes through menopause, a man may be going through andropause, and unfortunately the couple is more aware of menopause, so they seem to blame all the problems on the woman, but the reality is the low testosterone in the male makes them less able to handle stresses and stuff like that. So the whole couple has to be treated when they go through aging process. Both menopause and andropause need support, which is start from sleep, nutrition, exercise, herbs, etc. So neurocognitive hypogonadism. Sexual symptoms, I think we all kind of expect to talk about that first, but we'll talk about it now. Low testosterone is associated with decreased sexual function in both genders. It can cause decreased libido, the decreased desire in thinking about sexual activity, decreased ability to have a diminished orgasm. Can happen because of low testosterone and orgasm, the inability to have an orgasm, and you also see some pubic hair thinning and these type of things. Of course, erectile dysfunction. Additional symptoms for males on the one-hand side is increased insulin resistance, which can obviously, what you're going to find, can also exacerbate the testosterone and make things worse. Erectile dysfunction, and they also have other risks such as heart disease and sleep apnea. I don't know why those are under sexual, but I think, oh yeah, increased risk and symptoms. Okay, in women, I also mentioned, this is a side note there, but decreased sexual function is quite prevalent in both genders. If you look at the physiological consequence of hypogonadism, that's important because it gives us some goals as to where we're going to go as far as treating this. There is decreased testosterone production, decreased action of the HPG axis. We talked about hypogonadal axis. We see decreased testosterone functions, decreased sexual function in men, the lower nitric oxide and anabolic activity, increased cortisol, increased prolactin, and decreased FSH and LH. And of course the decreased male reproductive ability. So all those are some of the consequences of low testosterone in men. So of course our goal is to remediate those, to increase all these functions that were low and to decrease the ones that were excessive. We want to get down course on prolactin. With that in mind, we look at some of the herbs that have specific actions to help testosterone function better. In general, we can call these phytoandrogens or androgenogenic. Androgenogenic are herbs that can promote testosterone function. We can talk about functional mimetics of testosterone, herbs that mimic some of the functions of testosterone. These would be the herbs that mimic like nitric oxide regulation, herbs that mimic dopamine upregulation. So testosterone-enhancing herbs can either have direct androgenic activity, they can increase endogenous androgen function, or they can mimic specific actions of testosterone. One of the first we're going to look at here is mucoprensis. And all the information you see here is going to be on the website, yourhormones.com, as well as testogain.com. So I want to go through some of the key points here. But I want to encourage you to sit down and read them all, go back and read some of the primary research. It's always good to read the papers yourselves. You become very familiar with the actions of some of these herbs. You really appreciate how underutilized these are in the ability to raise testosterone levels and the ability to increase testosterone function as well as testosterone levels. The velvet bean affects the hypothalamic pituitary axis, so it can raise testosterone LH. It increases sperm quality and concentration, so yes, it can help with fertility issues. It also can calm down the excessive cortisol that we said can be anti-androgenic. And animal studies confirm it also can help with sexual behavior as well, sperm parameters, etc. It can also decrease prolactin. This is very important because the hyperprolactinemia is one of the causes of male hypogonadism, and this is due in many parts to L-DOPA, the constituent in mucana that suppresses excessive prolactin. Again, a big problem there. And of interest in men, low testosterone increases risk for blood sugar disorders, and so mucoprensis is one of those that affects blood sugar as well. And in fact, it's been so well researched that people conclude that it should be used for diabetes-induced erectile dysfunction. A number of papers on that. So mucoprensis in and of itself is a very beneficial herb for hypogonadism in men and some of the comorbidities such as hypogonadism and hyperprolactinemia. Tribulus terrestris also promotes testosterone production, so it can actually raise testosterone levels, statistically within days. It can also, as well as raising levels, it can also help with sexual desire and function. It does this by raising nitric oxide. So again, we see it has both androgenic and androgenogenic properties to raise androgen levels, and it has testosterone function mimetic properties. It helps mimic one of the functions of testosterone, which is to raise nitric oxide. And it talks about how its ability to increase a number of different properties here. I also mentioned some of the properties it does in women as well, but it raises nitric oxide and sexual function in men. Lepidium mei is maca root. It improves sexual function in both men and women. Of interest, it's a cruciferous vegetable, so when you think about estrogen detoxification, which is important in men, Lepidium maca root is important for that as well. We're going to see the excessive estradiol, or toxic estradiol, has androgen or testosterone opposing activities, so that may be one reason why maca works. But independently, they found that it helps with fertility, increases sexual behaviors and aphrodisiac. It has a general adaptogen and shows anabolic activity. So it's a number of interesting properties that are beneficial. Damiana leaf, Turnura diffusa. The old scientific name used to be Turnura aphrodisiaca, but they changed that in fear that the plant would be wiped off the face of the earth, overutilized. So Turnura diffusa used to be called Turnura aphrodisiaca. It's a significant sexual stimulant causing engorgement of erectile tissue, actually in both genders. It's also an adaptogen, helps with blood sugar. It's an amazing herb that has a number of different properties, helps with nitric oxide. Turnura is definitely an herb that should be part of testosterone enhancement. It raises testosterone function, and it helps with some of the collateral function of testosterone, such as nitric oxide and stress adaptation. Murray prairie bark can mimic the function of testosterone by increasing sexual desire and sexual function. So it hasn't been shown to actually increase testosterone, but it does mimic testosterone as far as behaviorally. It may be doing that because of its ability to control glucocorticoid activity, excessive glucocorticoid activity. It also can increase acetylcholine activity, which is involved in the sexual function. Acetylcholine is a mechanism that improves sexual function. Kind of, just as you think of other neurotransmitters, it does that as well. So low acetylcholine can cause decreased libido and sexual function in both genders. This herb helps in that. Eleutherococcus, we're all familiar with that. It used to be called Siberian ginseng. Now they removed the ginseng name off. So you have to call it Eleutherococcus now. It has functions that mimic testosterone in a number of different ways. Helps with endurance, it's anabolic, it increases sperm mobility, anti-fatigue. It's protective against glucocorticoids, so again it controls the high cortical activities, etc. So a number of different properties that we get from Eleutherococcus as well. And again, I'm going through these quick because these things you want to sit down and study on your own. I'm just giving you a flash of, wow, these are interesting. Tongakat Ali, Uricoma longifolia, promotes testosterone function, so it's androgenogenic. It increases testosterone function, plasma levels in human as well as animal studies. It's definitely indicated for andropause. To talk about rat studies and sperm mobility, it was so effective that in some people it was just as effective as hormone replacement therapy. And it also has some anti-estrogen properties in it as well, which can reverse the effects of estrogen. So this herb can be very beneficial in raising testosterone a number of different ways, by increasing testosterone in and of itself, and also by stopping some of the anti-androgen activities, such as controlling excess testosterone. Panax ginseng, a true ginseng, can promote testosterone production directly. It's been shown that. It can show an increase in both plasma and free testosterone. It increases spermatozoan production. It can cause a rise in hormone levels. As we know, it's involved in stress adaptation. It decreases 5-alpha reductase activity, so we get the more beneficial testosterone, less of the 5-alpha reductase activity. Helps with nitric oxide. It does quite a bit of the things that we would want to do, something to do that helps with testosterone. And you're going to see that in a specific chart in a second. Ashwagandha, sometimes it's called Indian ginseng, with Withenia somnifera. It also directly promotes testosterone production. So again, we have another androgenogenic herb. A number of these are. It raises both testosterone and LH. Now, as you recall, LH raises testosterone. It also decreases prolactin, and other beneficial things that we want to do. Lower prolactin will increase testosterone. It has some testosterone receptor antagonist properties, which can be very beneficial in both genders, obviously. It has dopaminergic activity, so it has functional mimetic of the dopaminergic property. And of course, it's, some of the anabolic activity is known, and its ability to control cortisol. So a number of properties that we want to see in an herb that will make testosterone work better, remove interferon factors. Withenia is another one of those, as we've seen other ones as well. So these are the 10 herbs that are used in the formulation Testosterone to increase testosterone levels, to help testosterone function better, and to mimic specific properties, and to remove antagonizing factors. All these references, if you go to Testosterone.com, you can look up each of these references, and there's a PubMed ID number. Go back and read the primary research. I always encourage that, and you'll see some amazing stuff about each of those herbs. Testosterone.com/references. The specific actions of testosterone that I just ran through real quick, best visualized. We'll look at this chart here. We can line up all the herbs on the x-axis, and then put the actions on the y-axis there. And you can actually see each of these herbs have a number of attributes that improve the function of testosterone. Many of them are adaptogenic and androgenic. A number of them from here to here have been documented to increase testosterone production. More herbs actually have been documented to increase muscle deposition, protein deposition, anabolic activity. A couple of them, as we discussed, are dopaminergic, nitric oxide. A couple of them are antioxidant, and then some good things like the anti-proliferative. They help the nervous system. They mimic testosterone, increase sexual desire, increase sexual function. So a lot of these herbs have many of those properties, most of those properties. and so it's important to recognize that. Of interest, Leukococcus, I scoured the literature, and even though it's a very powerful adaptogen with interesting properties, I've never found one that actually says it is specifically androgenic. If you ever find one, let me know. I've always thought it was real masculinizing, but I could not find any paper specifically calling it androgenic. It's a powerful adaptogen, one of the strongest, but it's not as masculinized as we thought it was. Endocrine comorbidities. Looking at low testosterone is enough, of a problem to have to deal with. But unfortunately, when you have low testosterone, there are other comorbidities, other endocrine disorders that can accompany that. These can include thyroid dysfunction, adrenal dysfunction, hyperprolactinemia, the high estrogen, as well as insulin resistance, as I mentioned. And I'll also want to mention prostate disease can happen with as part of male health as well. These are a few of the papers I came across I want to share with you, very interesting. Hypothyroidism is associated with decreased sperm function and with increased erectile dysfunction in men that had hypothyroidism. So it can affect erectile dysfunction, sperm parameters, morphology, motility. So infertility in men, look at thyroid function. The association between delayed or premature ejaculation could be with hypothyroidism and hyperthyroidism respectively. So low thyroid function is associated with delayed ejaculation, with hyperthyroidism, premature ejaculation. A lot of that makes sense, but what we're talking about here is ejaculatory dysfunctions are associated directly with thyroid dysfunction. And this paper and others mention that if you fix the thyroid problem, you can fix the sexual function. Another paper, the last one, says erectile dysfunction is extremely common in males with dysthyroidism. Treatment of the latter, of the thyroid disease, often restores erectile dysfunction. So this is one of a number of papers that was saying, yes, you should treat the thyroid dysfunction. That can help with erectile dysfunction as well. And then they said that treatment, basically it says you want to maintain normal thyroid function for a few months before you may get the full results, but it's interesting. Like I said, I see a lot of these occurring together. It's a very common comorbidity, more than we realized in the past. Sexual dysfunction and dysthyroidism. These are some of the other signs and symptoms of low thyroid function. These are actually on another website called Thyroid. You can look at that. It has a questionnaire you can print out. Like here's right here. Here's a questionnaire you can print out, use your patients as part of the screening process. Again, it's just screening out symptoms, and it pretty much tells you what statistically probability is. And of course, you need to get lab tests to confirm a diagnosis. But this can be very beneficial. It's on your hormones.com questionnaires. It's also on the other website, Thyroid. Thyroid.com will teach you more about the thyroid if you're looking at that as a comorbidity in male hypogonadism. And at the same time, that will show you how the thyroid has a number of different actions it has to increase thyroid function and how the herbs work with that, similar to what I do with Testosterone. The adrenal-gonadal connection is pretty significant in male hypogonadism. And when we talk about the adrenal gland, we talk about two axes, the sympathadrenal system and the HPA, hypothalamic-pituitary adrenal axis. Both of those can dramatically affect the HPG axis. So again, both of the adrenal axes can affect the HPG axis. The sympathadrenal system, which, as you know, is involved with the production of catecholamines. There's a couple of papers I looked at. Research suggests that increased catecholamines can inhibit the production of testosterone under condition of extreme stress. So while you may get that quick little burst of energy and speed with catecholamines, the consequences as directly it affects the testes to decrease testosterone function. So that's why we don't want to keep our adrenaline running too long, guys, right? It can directly affect testicular function to decrease testosterone production. The HP A axis, hypothalamic-pituitary adrenal axis, we understand the different stages of stress that are involved here. In the early stage, you can have the cortex hormones male become elevated, including not just cortisol, but DHEA, androstenedione, etc. So you can also see some of the androgens become elevated in the first stage, which is good. The body's trying to adapt. It's not just raising cortisol to protect you from injury. It's also raising androgens to help you with, the fight part of fight and flight. Under continued stress, cortisol continues to climb while the others start to drop. And eventually, you'll see a drop in all the hormones, cortisol, etc. So different stages of stress, you'll see different patterns of of adrenal hormone function. And the different adrenal hormones, as you can see there, include the corticoids, the glucocorticoid, the cortisol and deoxycortisol, the other mineralocorticoids right here. So these are glucocorticoids, mineralocorticoids, androgens, and progestogens. These are all made by the adrenal gland. In the early stages, they may all pulse. This is why sometimes you'll see a little spike in progesterone and some of the other hormones during the acute stage of stress. But eventually, these all start to drop, and cortisol levels rise at the expense of those. And this is what we wind up seeing eventually. Is progesterone levels get shunted into cortisol. These levels rise. We see less androgens, less estrogens, and there's actually a shunt, so these can actually start to drop as well. The body kind of pushes them towards cortisol. So that's very familiar. I think we've been talking about the cortisol steal, the cortisol shunt for years. But keep that in mind. The adrenal gland may be the cause of hypogonadism as well. And some of you may recall I gave a pretty lengthy talk on stress adaptation homeostasis. It's on both Douglas's website and my YouTube account. And it talks about the 12 different systems that are affected by the adrenal gland by stress, not just adrenal gland and the gonads, but other ones as well. And I'll also talk about that at length with adrenal men. If you think adrenal dysfunction is contributing to gonadal hypofunction, then this is definitely something we need to be looking at. And I've had men that don't respond to testosterone intervention therapy, whether it be hormone replacement therapy or Testosterone, until we also address the stress factor with adrenal men and some of the cause of the stress in their life. You can see this on the websites as well, the specific actions of adrenal men. Again, a number of different herbs affect 12 different regulatory systems. I think this is why that formulation is so effective, because it's able to work with not just the adrenal system, but all the other secondary systems that are affected. And of course, one of those is the gonads, which we'll talk about today. Another problem is hyperprolactinemia. Hyperprolactinemia in men causes decreased libido, erectile dysfunction, infertility, and gynecomastia. Causes in men may be hypothyroidism or hyperestrogenism. So another reason to check thyroid, another reason to keep the estrogens under control. Other causes could, of course, be tumors in or near the pituitary gland, and a number of drugs that can block dopamine activity. And in fact, as I mentioned earlier, one of the herbs we use has L-dopa in it, and that's what can actually decrease prolactin. Prolactin happens when the anterior pituitary makes too much prolactin, which affects the testes directly to lower testosterone. And then, of course, it also can go back and shut down the loop. It's decreased FSH and LH as well. Mucuna decreases prolactin levels, and significant increase in sexual behavior through L-dopa, because that can has been noticed because the prolactin suppresses excessive prolactin suppresses sexual function. So L-dopa is able to fix that. So again, mucuna parenthesis inside Testosterone. That's one reason why it's inside there, because a very common comorbidity is hyperprolactinemia. And even if you don't have hyperprolactinemia, it still helps with sexual function and some of the other attributes that mucuna parenthesis has. Poor estrogen metabolism. From the pathway we talk about estrogens, we want to keep in mind that high estrogen levels can increase SHBG, as we mentioned. As I also mentioned, SHBG is called capital T, small e binding globulin, and because it decreases bioavailability of testosterone. Another consideration when we look at estrogen is you don't want too many of the bad estrogens. Just as the 16-alpha-hydroxyestrone increases breast and uterine cancer in women, it can contribute to prostate cancer. It's a contributing factor that has to be controlled as well. Our goal is to make more of the good estrogens, the 2-hydroxys, and if we're lucky, we want to make the really good estrogens, the 2-methoxys. 2-hydroxys don't cause cancer as bad as these, aren't as stimulating as these are, so they don't cause cancer. And these are actually anti-cancer. The 2-methoxy estrogens, especially 2-methoxyestradiol, causes apoptosis of cancer cells in both genders. So it's our way of, by design, we actually can make our own chemotherapy. If we can do 2-hydroxylation and methylation, is a process right here. And the way that I've been doing that for years and seeing some remarkable results, as have many clinicians, is pushing 2-hydroxylation with DIM enhanced, which is designed to decrease the production of 6-alpha-hydroxyestrogens and increase 2-hydroxyestrogens, and that push methylation with B complex because it has the activated folic acid, it has the activated B6, has the methyl form of B12. Those are the three that are most critical for methylation and the ones that patients have more problems with. They may not be able to activate folic acid or activate B6 into paradoxal 5-phosphate, or they may not have the best form of B12, the methylcobalamin. So between 2-hydroxylation and methylation, we can create these really good estrogens that are anti-cancer. And obviously, we're kind of cleaning out the estrogens. We're reducing the pool of estrogen to a less interferon form that can cause less problems with testosterone interference. Insulin resistance, again, another comorbidity. Unfortunately, it can both cause and be caused by testosterone problems. Insulin resistance can actually decrease testosterone production by interfering with latex cell function in men. Even 75 grams of of glucose causes 25% production in total and free testosterone in healthy men. So slamming down a really high amount of sugar can dramatically drop down blood sugar. And these are in men that had both normal glucose tolerance and men with type 2 diabetes. So it wasn't just the type 2 diabetes that saw the testosterone levels drop 25%, but men with normal testosterone levels who hammered down 75 grams of sugar saw their testosterone production drop. Hypogonadotropic hypogonadism in men secondary to type 2 diabetes. 1/3 of men with type 2 diabetes have low testosterone concentrations with low LH and FSH. So we're seeing both primary and secondary causes. So blood sugar is definitely not our friend. It may be why at the top of the list of treatment, I like to use alpha-lipoic acid because it has an ability to help with high blood sugar in men, and also help with the detoxification. Just I don't know. I've just found really good results with the alpha-lipoic acid there. Gymnema, chromium, vanadium. Douglas Lash has a number of different products that have these in it. One of the notes about vanadium, though, this is been my experience, and because all the work I do looking at the different functions of all the hormones, I just don't look at insulin resistance. I say, what do these therapies do for other hormones? And I was concerned when vanadium in excessive dosages can suppress FSH and LH. It can suppress testosterone levels and sperm count. I just grabbed one paper you can look at there. I have the number there. But I've been looking at some of these studies for years and some other papers. So I'm more inclined to use lower dose of vanadium, like Douglas has a 250 microgram formulation. I'm more inclined to use that than milligram dosages because there's information about vanadium toxicity as it is about vanadium, sometimes even more about vanadium therapy. So be cautious with that. People that are looking for the magic hammer and hitting the patient with high levels of vanadium may not be doing something in their best interest. Use a little vanadium. They need some chromium, gymnema, alpha-lipoic acid, and obviously dietary and lifestyle, and fix the testosterone. It's interesting. Low testosterone causes insulin resistance, but insulin resistance causes low testosterone. So one of the therapies is to give testosterone. That can also help overcome this. Or use Testosterone. That can raise testosterone levels, etc. Prostate disease. We can't talk about men's health without taking at least a minute to recognize that prostate disease is a problem. This has been described in literature as androgen hypersensitivity, where all of a sudden the prostate, which we were so thankful that it responded to testosterone all these many years, now starts to become hypersensitive. We start to see increased proliferative activity because it becomes sensitive to testosterone and it becomes sensitive to the higher testosterone. These are both androgen receptor hypersensitivity. So we're dealing with androgen receptor hypersensitivity here. And they also have increased inflammation, increased proliferation. So, of course, one of the therapeutic goals in these men where the prostates become too sensitive is anti-androgen therapy, which should have secondary anti-inflammatory and anti-proliferative properties. And that's what I've been able to put together and have some really good results with this in dealing with men with some severe prostate disorders. This includes herbs that have anti-androgenic and specifically androgen receptor antagonism. Like I was talking with a physician recently about the fact that they use Lupron in men that have, prostate cancer to lower testosterone function, but it doesn't necessarily block androgen receptor function. Those androgen receptor antagonists they use those down the line if the Lupron one fails. But what I'm saying is we have natural herbs that we can do that right away. If men's prostates become hypersensitive, we can decrease testosterone production and we can decrease androgen receptor function by using herbs that have been documented as androgen receptor antagonists. We decrease DHT production because 4 of those herbs that have been documented as 5-alpha reductase inhibition. Basically, they cause androgen deprivation is what has been talked about in a couple of literature. They actually lower testosterone levels. Of interest, you quit taking this, testosterone levels can come back up, so they don't cause like a permanent chemical castration. They just temporarily controls testosterone. And of course, some of the other benefits, anti-inflammatory, anti-proliferative, antioxidant, analgesic, are important in prostate dysfunction. Those are highlighted as well. And some of the other nice little sidelights is they help with blood sugar disorders and lipids, and they help with stress adaptation and a little bit of detoxification. So the most important thing about men with prostate is we can both decrease testosterone production and decrease androgen receptor function. But with Testosterone, for those of you that when we started this webinar, I was hoping to talk about prostate as well as hypogonadism. So look at that. Look at the website. Testosterone for men will redirect you right now to your hormones until that website's finished. But the log information there about androgen control. All these formulations I mentioned today that I designed, plus 3 more of them actually, I got 7 of them there, are designed now to be dosed a certain way. What I've found is I always like to start patients on like 2 a day, and then I'll increase it to 4 a day. Then when they say to me, you know, I feel great, I'm getting the full results I want, do I still need to take 4 a day? Then we can wean it back down to 2. I found it to be very efficacious. I start the lower dose because, you know, you can't go from 0 to 60 in one day. So we start some of the biochemical changes, do some of the dietary lifestyle changes, then do a very therapeutic dose of 4 until we get resolution of the disorder, whether it be thyroid, testosterone, adrenal, etc. And then we get the results they want. I'm very pleased to see us be able to wean them down. So I was doing this so much with these formulations that the current label actually uses the 242 protocol to help our patients achieve a high quality of life, and also they appreciate that after they achieve that, we can drop them down to maintenance, and we're still able to maintain that. And on yourhormones.com, I have a number of articles talk about personalizing therapies. You know, I don't want us to get into one size fits all. That give this for that. We need to be able to customize dosages and use other adjuvant therapies to get things working better. Like, for instance, whenever I see any type of inflammatory disorder, Wolf enzyme is typically part of my therapy as well. So obviously, keep that in mind for any of these inflammation disorders like prostate disease. The next one, some of the previous works I've done, these are a few years back, I did phytotherapeutic management of endocrine dysfunctions and phytotherapeutic of thyroid dysfunction. Douglas has those on the website. I also have webinars on my website as they do. So there's a lot of educational material available for you to review. Most of the information you'll find, actually all of it, is on yourhormones.com. And webinar notes I'm going to be putting on yourhormone.com events. We're just going to make that, we're going to upgrade that section out the next week. So check that out. Check out yourhormones.com and YouTube links from that website. Thank you for this. I look forward to working with any of you. You can directly contact me at that phone number. That's my office. And with any questions you have, or email me personally. My responsibility is to be able to support you, and it's a great joy to help and work with other clinicians around the country. I look forward to hearing from as many of you as would like to contact me. Thank you.
Great. Thank you very much, Dr. Collins. That was a really great presentation, very detailed, a lot of information. So we appreciate all the materials and website that you have available for further information. And since we're you know, a little bit past the hour, we can take a couple of questions. But if your question is not answered, like Dr. Collins said, please reach out to him via email, and he would be happy to help you out. So during the presentation, there were a few times that I think we lost your voice. I guess the connection kind of cut out. Would you mind repeating the information about diagnostic tests on slide 11 when you talked about the pituitary and the liver testing, how that relates to testosterone?
I'm sorry, slide 11?
Yes.
The pituitary gland and what?
And the liver test, diagnostic testing, yeah.
Oh, yeah, but when we talk about diagnostic tests, and I was talking about SHBG, sex hormone and binding globulin. Was that the area they cut out? And SHBG is sex hormone and binding globulin. The other name for sex hormone and binding globulin is capital T, small EBG, testosterone estrogen binding globulin. When that level gets too high, it preferentially binds testosterone, even though it's induced by estradiol. And so looking at that's very important. If SHBG is high, we want to take measures to decrease it. And that can often be by helping metabolize estrogen, as I mentioned later on in the webinar. Did that go through that time? Okay.
Yes, it did. Thank you very much. And another question came in about, I think you mentioned, cholesterol levels. But obviously, if they're too low, what's too low in your opinion, and how would you increase cholesterol production?
I like to see testosterone, cholesterol within the reference range. I don't want to get below the reference range. I've seen too many doctors say, oh, it's even lower than it should be, and that's not what it should be. So different labs have slightly different ranges, so I'm not giving an exact number. But when they say that LDL should be this, within this range, keep it in that range, and you don't want it to be below that range. It's because that's the normal physiological range of LDL. And of course, one of the best things you can do is to quit doing things that, get rid of the LDL lowering drugs. There are a few cases, though, when some patients will actually have low LDL genetically, and unfortunately, those people have problems because LDL also carries fat-soluble vitamins, and some cardiomyopathies may be associated with the inability of LDL to transport coenzyme Q10, which we've talked about a lot in the past. So those are patients that have actually had them increase cholesterol in their diet to get the LDL levels up. So yes, if it's too low to the point where you're getting cardiomyopathy and other problems, then you actually have to raise some of the, get the LDL within therapeutic range.
Okay, great, thank you. Mm-hmm. Yep, and you were talking a lot about the testosterone to estradiol ratio.
Right.
Is there a specific ratio range, and is that the same for saliva and serum levels?
The ratio range, as I showed in that one document, is something that is based upon the saliva or serum. The saliva one reference range is 4.18 to 181. Now that's based upon the lab I use, which has a normal reference range of testosterone being 31 to 192 and estradiol being 1 to 7. Now, of course, you can determine any reference range, but if you're going to do T to E, you take the first one and the second one. What you do is you take the 31 divided by 7, which is going to give you 4.18, and then 192 divided by 1. Actually doing it wrong. You take that, you have to do moles. I just said do moles. You take the 107 and divide by 25, and then the 665 divided by 3, and that gave you the 4.1 to 181. So you take the low of the first analyte divided by the high of the second analyte, and then that's the low end of the TD ratio. The high end of the TD ratio is the high of the first analyte divided by the low of the second analyte. And you can do that for any hormone ratio analysis, DHA to cortisol ratio, P to E, anything. It's an amazing skill to have as a clinician to be able to do percentile analysis and ratio analysis, if we're going to talk about relationships of hormones to each other.
Okay, I understand
Okay, what?
Sorry.
Sorry.
I was going to say, I understand the ratio, though. You have to calculate on your own. There aren't any lab tests that will automatically calculate that for you, correct?
At this point in time, I think PD ratio, a lot of labs try and do that, but some of them are doing it wrong because some of them actually compare picograms to nanograms. Figure that out, But the ones who are doing it right are doing picomoles to picomoles, and that some labs are doing that properly, and that can be beneficial. But it's good the clinician has the skill themselves, especially now. I've been doing some looking at testosterone to both estrogen ratios. So I would do testosterone to estrone plus estradiol ratio to get a total estrogen load, and that's going to give me some more insight as well. Again, some of these things we were ahead of the research. We started doing ratio analysis. As I said, I started doing that in the mid-90s, but now we're seeing more and more papers on it. But testosterone estradiol ratio, that actually has quite a few good studies on it as well. I think you'd be pleased to see some of those papers.
Okay, thank you. And we have a question, are there any contraindications for using Testosterone?
As a general rule, I try to tell patients not to use Testosterone around, and not to use any of these herbal formulations around pregnancy. We don't have enough research, you know, to be using any of these herbal formulations I use around pregnancy. And I'm one of the purists. I think that a pregnant woman should basically be dealing with a healthy diet and use herbs as little as possible, unless we have evidence of their safety, like ginger for nausea and this type of stuff. That's just one of my beliefs. And because some of these herbs are very profound, I don't want us experimenting on you know, unborn children about what some of these herbs can do to their hormone levels. So across the board, I say, you know, avoid all my formulations say do not use during pregnancy, and that's my primary concern. Beyond that, look at the clinical picture. If you're dealing with prostate cancer, don't use Testosterone. Look at trying to decrease androgen sensitivity. Use Testosterone for men. It's named for that. Women with polycystic ovary syndrome should not be using Testosterone. Now, some women with low testosterone, they're doing great on Testosterone. In fact, you know, it's beneficial for both genders. But whenever you have an androgen excess picture, like polycystic ovary disease in women, do not use Testosterone. They need Testosterone for women. So pregnancy and then of course clinical pictures that are quite obvious will tell you when not to use Testosterone.
Okay, thanks. And the last question while we're talking about Testosterone is if there's any difference in dosing between men and women.
Men and women both respond to the 2-4-2 dosages, but I've seen some women, they obviously, as you would expect, they get the full results quicker, and they get to wean off the 4 quicker than men do. And I've had a number of women that, when I talk about personalized dosing on the website, they may just need one of the Testosterone. But most of them I have them start with 2 and then 4 and 2. But again, women usually are able to achieve therapeutic results much quicker than men and able to get back to maintenance dose. Sometimes like within a month, it's you know, they're able to wean back down.
All right, thank you. Well, we're out of time for questions, but I want to thank you so much for spending your afternoon with us and delivering a wonderful presentation. And just to remind everybody that a recording of this webinar will be available at douglaslabs.com starting tomorrow, as well as accessible through the Douglas Labs YouTube channel. And stay tuned to our website for next month's presentation. So thank you all again, and have a wonderful afternoon.
Thank you.